Welcome, everybody. I see that many of you are joining us now, but we'll start. My name is Marlène Bras, and I'm the Director of HIV Programs and Advocacy Department at the International AIDS Society. And it's my pleasure to welcome all of you today for this webinar. And as we start, I would like to remind you of a few housekeeping rules. So please do ask the question you have for the presenters and the panelists in the Q&A box, and keep the chat for any technical issues you may have or for introductions. The slides and the presentation is being recorded, and the material will be shared with everybody after the webinar. Next slide, please. So it's a great pleasure for us today to have this webinar. And this webinar has been organized in collaboration with the WHO and Unitaid. If you can go back to a previous slide, please. Thank you. And I would like to thank Shona Dalal from WHO and Smilchka de Lucini from Unitaid for supporting the IS Person-Centered Care Program team to prepare today's exciting program. I would also like to extend my thanks to Hayward Bihanu from the Clinton Health Access Initiative for their support in planning the event. And finally, I would like to thank and acknowledge Gilead Sciences as a strategic partner of the Person-Centered Care Program at the IS. Next slide, please. So this webinar is a follow-up activity to a full-day pre-meeting which was held last July in Brisbane, in Australia, titled Putting People First in the Prevention, Treatment and Care of HPV-related Cancers Among People Living with HIV. And this pre-meeting was organized by IS and Unitaid. And it was a fantastic opportunity to convene this event alongside of IS 2023, and the city where researchers Ian Fraser and Jian Zhu at the University of Queensland invented the HPV vaccine. Next slide, please. The pre-meeting consisted of 5 sessions, and the recordings, the slides, the meeting report are all freely available on IS+. And you can see there's a little QR code on the slide, and by using this QR code, you can access them directly. So for those who are not used this platform yet, it's a very exciting new feature of IS, and IS Plus is a new interactive digital platform developed by the IS to provide free HIV-related educational resources and virtual live events to empower scientists, policymakers, and community activists around the world. You can access this free state-of-the-art platform whenever you want. And we really encourage you to do it and to bookmark the site in order to be able to access all the new recording posters, toolkits, and so on. And without further ado, I'm very, very honored to hand over now to Adiba Kamarud-Zaman, who will provide a quick recap of the pre-meeting. Adiba, the floor is yours. You're on mute, Adiba.
Okay. Thank you so much, Marlena, and greetings to all of you from Kuala Lumpur. It's starting to rain, so I might need to compete with the thunderstorm. Let me know if you can't hear me. One sec. Give me 2 minutes. So, for those of you who are fortunate to join us in Brisbane, we had a fabulous meeting, and for those who were also able to join us online, hope you agree that we had wonderful pre-meeting, as you heard, thanks to our sponsors and we are now continuing the engagement around cervical cancer and anal cancer elimination. So the goal for that meeting was to raise the ambition and our call to action, which include to put people living with HIV at the center to foster inclusivity, long-term solutions, and faster, more effective change, and to allow the passion and commitment that was so palpable in that meeting that we had in Brisbane from communities as well as healthcare workers to raise the ambitions that we all have towards elimination of HPV-related cancers, cervical cancer to start with. To increase the levels of health literacy within communities regarding the importance of vaccination, screening, and treatment as prevention for the development of HPV-related cancers. And to call for the allocation of investment and resources to train clinicians to perform anal screening and high-resolution anoscopy for routine anal cancer screening and early treatment to be the standard of care for people living with HIV. We want to raise awareness, especially of anal cancer among people living with HIV and clinicians, to normalize routine digital anal rectal examinations for all people living with HIV as part of regular sexual health checks. We also hope with this awareness raising to improve HPV vaccination coverage among people living with HIV up to 45 years of age by reducing financial and policy barriers. We want to see the implementation of simplification of screening, triage, and treatment options to ensure the same level of outcomes without needing the same level of intervention. We want to see an optimization of existing infrastructure and health systems to scale up point-of-care HPV DNA testing. We hope to continue to advocate for a reduction in the price of HPV tests and vaccines, working with ministries of health and all levels of government funders, private sector, manufacturers, and suppliers to deliver high-quality testing services at an inclusive and equitable cost. We discussed in this pre-meeting the need to convey to governments that investing now in HPV, HBV, and HCV programs result in a reduced number of cancers in the future, which reduces associated treatment costs and loss of productivity while enhancing quality of life for many people. And finally, we propose to extend the World Health Assembly resolution to the elimination of HPV-related cancers rather than just the elimination of cervical cancer. So as a next step in our efforts to end HPV-related cancer for all, and especially for people living with HIV who are particularly impacted, we are excited to convene this follow-up webinar program, and thank you all for joining us from around the world, and also a special thanks to all our speakers from around the world for joining us today. And so with this program, we will first hear from Meg Doherty. I think Meg doesn't need any further introduction from the WHO as head of the Department of HIV, viral hepatitis, and STD at WHO, who will share the latest guidance. We will also hear from Benda Kataka, who is a health advocacy and behavioral change specialist, and the importance of and the crucial role of civil society. Karen Campbell from the Daffodil Center over in Sydney, and it's getting quite late for Karen over there, will share updates from the Unitaid technology landscape and the latest modeling supporting screening guidelines. She'll be followed by Helen Kelly, also from the WHO, who will share key lessons learned on the integration of HIV and cervical cancer screening programs. Doreen Teti from Malawi will share the successful integration approach taken in Malawi. And Maribel Almonte will share efforts to improve access to high quality HPV tests. And moving to anal cancer, Andrew Grulich, also in Sydney, will share the latest evidence supporting a scale-up of anal cancer screening. Mary will then moderate the discussion and start by inviting lived experience advocate Sally to share her reflections before opening the floor to questions from all of you. So as you can see, we've packed a very dense and heavy program in this hour and a half, and we are very excited to have you join us. All the speakers' bios will be included in the chat to save time, so you know who they are. And so one final advertisement for the IAS before I introduce our first speaker. Of course, I would like to encourage you all to come to AIDS 2024 in Munich. As you know, it's the World AIDS Conference convened thousands of people living with, affected by, and working on HIV to share knowledge, best practices, and lessons learned from the HIV response over the past 40 years, as well as from the responses to COVID-19, Mpox, and other public health threats. This year, AIDS 2024's theme is Put People First. And putting people first means thinking of solutions from the point of view of those most affected. Ending the HIV pandemic as a threat to public health and individual well-being will require the worlds of research, healthcare, activism, and policy to agree on fundamental principles. And so this will be the first large AIDS conference that will be convened post-pandemic. We're all excited to have you there. The second after Montreal, but Montreal was still in the clouds of COVID-19 pandemic. So hopefully we will have more in-person participation now that, hopefully we have the pandemic somewhat behind us. The highlights for AIDS 2024 include a diverse pre-conference program on 20th and 21st July, dedicated talks on HPV-related cancer within the conference program, and of course, our signature global village for activists and community representatives. So with that advertisement, I now move on to introducing Meg Doherty, like I said, who needs no further introduction, Director of the Department of Global HIV, Hepatitis, and STI Programs at the World Health Organization. Over to you, Meg.
Thank you very much. And I really appreciate the opportunity to come and speak and be part of the panel that we had in Sydney. It was really a great experience to be part of that pre-meeting. And my role in the next 5 minutes is to give you a few updates around HPV-related WHO guidelines guidance, especially focusing on people living with HIV. So let's just get into it. Next, pardon me. We've heard in the speaker presented as well in the background that we know that people living with HIV have a twofold increased risk of HPV acquisition and a twofold decreased risk of being able to clear once infected versus the general population. And this has been the basis of having a very focused area of work on HPV and cervical cancer among people living with HIV. And already we know that cervical cancer, approximately 80% is attributable to HPV. So this concern is also a particularly high risk for women living with HIV, where that increased risk of acquisition leads to a 6-fold increased risk of cervical cancer. And so we know as women are aging and all people are aging living with HIV that we're starting to see increases in cancers, people living with infection much longer, and that we have ultimately the ability to prevent this cancer and also to prevent the development of cervical cancer for our youth. The other thing that we discussed, as was mentioned before, was the anal cancer risk related to HPV among people living with HIV. So that increased risk is known among men who have sex with men, that there's 85 per 100,000 risk there, 32 for heterosexual men, 22 per 100,000 for women living with HIV, and 19 per 100,000 for MSM without HIV. So we also know that HPV is a risk for anal cancer, and among that, people living with HIV are at an increased risk. And also anogenital warts increase among people living with HIV. So with all of this risk, what are we doing about it? Well, we're monitoring to know what the cervical cancer incidence and mortality is. Having good data allows us to target our work. And in the past, in 2022, we had over 600,000 cervical cancer cases, 340,000 deaths. And I think what we see is that there's a geographical location incidence in blue, new cases in sub-Saharan Africa, as well as the intensity of deaths as well is in sub-Saharan Africa. So we know that we need to do a better job of getting out the HPV vaccination. to address cervical cancer in screening and treatment, which we have very good guidelines for, and to know and to ensure that people are on treatment if they're living with HIV, because being better suppressed will also let that person who's infected have a better outcome if they are indeed infected with HPV as well. So the reminder that we have very ambitious targets around cervical cancer elimination. And these are our threshold and targets that were for elimination. And to be honest, right now, elimination of a public health threat is becoming a really important, I guess, focus of the WHO. We're looking at multi-disease elimination. And if we can achieve an age-adjusted incidence rate of 4 per 100,000 women living or acquiring and having HPV and cervical cancer, we're going to be able to reach some of these targets. Like with our HIV targets for 2030, there is a screening, treatment, and identification of precancerous lesions that are occurring that have been set for women living with HIV, which is 70% are screened and 90% are identified with the disease and move on to treatment. And this should, if attained, should reduce mortality from NCDs by 30%. But we know this is important work, but we need to have better guidelines to be able to help us. And one of the exciting things that happened over the last year or so is that girls now, we can have recommendations that optimize the vaccination coverage, where we've been able to move from a 2-dose schedule for girls starting at 9 years old to a 1-dose schedule for 9 to 20-year-old. And I think that this will help us to ensure that all girls are getting vaccinated early and that we can prioritize the vaccination for immunocompromised people and that they go beyond the age of target with ideally 2 doses, potentially 3. So that evidence base is something that we're working on to make sure we can identify how best to reduce and optimize vaccination, but also ensure that people living with HIV are well covered. So how is this single-dose schedule adaptation and adoption happening? I think 37 countries have already adopted this single dose in high income, middle income, and low income. But you can see some of the gaps that we're seeing in sub-Saharan Africa and locations where we have the highest burden of people living with HIV. So more to be done there to protect our girls prior to any infection and to protect, we hope in the future, our boys as well. Have they ever had a lifetime screening? As I can see here is as well a part of the second target here about screening and treatment, that we are seeing very large gaps on only 0 to 9% ever having a lifetime screening in some of the low and middle income countries. And to be able to reach that second target, this is going to have to turn more orange to green to be able to reach those targets to really achieve our elimination goals for cervical cancer. So what has WHO done? WHO has put out a number of guidelines that talk to and speak to HPV as well as cervical cancer. We have them not only in the cervical cancer guidelines for women living with HIV that outline specifically what we need to do, but it's also found in our key population guidelines, and of course, the cervical cancer prevention toolkit and many other documents that you're going to hear about today. And we encourage you to go and look at those and make sure that your country has access to them and are starting to use them. Just to remind you what the summary recommendations are for the strategy for addressing both. Once we've done vaccination, now we look to the screening, triage, and test treatment. And for the general population, it's an older age and every DNA test every 5 to 10 years screening interval. However, for women living with HIV, we want a screen, triage, and treat approach where we do an HPV DNA as the primary screening test starting at age 25 and every 3 to 5 years there later. And that once you get that DNA testing, then we can try at that point in time to link to care and ensure that there is appropriate treatment given. Right now, we've also had recommendations when doing this screening, one can use a self-collected sample. And this is part of recommendations that have already moved forward for self-sampling for cervical cancer screening. We also are looking to see how the policy and commitments are being, I guess, adopted and taken up around the world. And as you can see in this slide, it says, have our recommendations for women living with HIV around screening and treatment for cervical precancer lesions, have they been taken up in the country adaptation? And again, we're seeing, yes, at least this is good that we're starting to see green being infiltrated into low and middle income countries, primarily supported, I would say, under programs that have support under PEPFAR. But we need to do more, and we need to ensure that all of those countries with the highest burden and of both HPV incidents and cancers are actually integrating this into their policies. So 50 have taken up and 19 plan to do so. So just let's say are wrapping this up from the perspective of WHO, what do we want to see coming in the future? We'd like to see greater support for ministries of health in adopting our guidelines that are out there and increase focus on impact and bringing in the vaccination. We're hearing good words that perhaps PEPFAR is also very supportive of early vaccination. We'd like to hear more about that. We'd like to see the services integrated into HIV services and also into cervical cancer or maternal child services, so that women can be person-centered. Women don't have to go one place or another to get their services. We'd like to be able to facilitate and see better monitoring, and so that we can target our work better, and strengthening with our links with the community. Certainly, we learned from our discussion in Brisbane is that we need to be able to be very close to community, and ensuring that women have this information is going to be part of addressing all the gaps out there. And this is just one step here of having this session today, and I look forward to hearing much more, and thank all the people who've been working at WHO, HRP, etc., who've put a lot of effort and work into this for WHO. So back to you, Adiba, and thank you very much for giving WHO a moment.
Thank you so much, Meg. Fantastic summary as usual of what's happening in in HIV and cervical cancer sphere and also beyond. So now we will hear from Benda Kithaka, who is a communications and health advocacy specialist and the founder and executive director of the Kilele Health Association in Kenya. She's also the secretariat lead of the African Cervical Health Alliance. Over to you, Benda.
Thank you so much, Adiba. And so good morning, good afternoon, good evening, everyone. I hope you can hear me clearly. My name is Benda Kithaka from Kilele Health, as you've heard, and I'm going to be talking to us about putting the role of civil society in cervical cancer elimination, basically in putting people first. And so I'm getting control of the slides as we're speaking.
Just click your mouse to take control, Benda.
Yes. I've tried that.
You have control now.
Okay. So yes, so cervical cancer elimination in Africa and the role of civil society. I am here before you as a woman living in Africa, a civil society activist, as well as an advocate for policy change. But at the same time, I represent a collection of organizations across Africa who are working as the African Cervical Health Alliance. And the African Cervical Health Alliance is an association of a collection of organizations that we've come together as a network of grassroots civil society organizations who are working in Africa across diverse geographies to put community action center stage in the elimination of cervical cancer in Africa. We are very young, about 4 months old from when we launched to the public. That was on the WHO World Commemoration Day for cervical cancer elimination. But the African Cervical Health Alliance members have been working together for over a year now with support from FIND to be able to put our voices collectively towards cervical cancer elimination in Africa. And there is a reason for this. Africa leads the world. We've seen from the slides presented earlier that Africa leads the world with AIDS standardized incidence and mortality. But that's not the only thing that Africa leads the world with. We also are leading the world with the number of cases of persons living with HIV and AIDS. We also have leading the world with a number of the communicable diseases as well as some of the non-communicable diseases. And therefore, this tends to put a strain on our healthcare systems. We also know that some of the countries have the least investment in healthcare in Africa. And therefore, coupled with the burden of the different types of diseases, we do need an urgent action in embracing the cervical cancer elimination action in Africa so that we're not left behind by the 2030 targets by WHO. Speaking of the targets for the WHO, we do know they're very clear metrics. We want to see number of girls vaccinated by 90% by the year 2030, or at least having mechanisms in place, 70% of women screened, as well as 90% of women treated. And as we've heard from Meg, there are clear metrics to this. We want to see the numbers coming through. But we know from a civil society action point that way before we get to the 90% of the girls vaccinated, we need to deal with the stigma, misinformation, disinformation on cervical cancer elimination and HPV vaccination. We do need to get women well empowered and also systems ready for these women to get to show up so that when we do, we can then be able to screen the 70% with high performance screening tests. And then we also need to have mechanisms for treatment for the 90% of women who are found to have anything suspicious, be it just cervical lesions, all the way to actual treatment of invasive cancers. Now, we know the challenges that we are facing in Africa. The reason being, I know the systems do tend to want to blame the woman for showing up late. And by saying that it's poor awareness that's leading to that, is the fear and the stigma in the system and in the communities that's leading to this slow showing up. But we also know there are other determinants towards how women show up and when they show up and how they bring their daughters for vaccination, the social determinants of health. To name a few, we have poverty. We know that some countries in Africa also bear the burden on poverty, gender inequality, access to care. All these are things that are not necessarily being measured, but that matter a lot in the cervical cancer elimination strategy. And so when we talk about late diagnosis, limited access to care, or even escalating numbers of cancers in Africa, as civil society, we see very clearly that we have a role to play in ensuring that this can be minimized. How so? We've learned from the HIV and AIDS movement globally, as well as regionally in Africa, as well as in some of the countries in Africa. For example, with coalitions forming, with organizations forming, with global support, the HIV and AIDS movement has demonstrated for many years now how respectful stakeholder engagement can be done, where we have global solidarity and a call to action, where we're able to leverage the resources, expertise, and shared lessons, where we're able to build best practices, and the HIV and AIDS movement has shown this very well. It has also shown how to destigmatize the messaging, and so that we're bringing a human rights-based approach to advocacy and to calling on governments to act for their populations. Again, determining how to be able to lead from a community perspective with advocacy, including equipping and empowering civil society organizations, and in return, their members, their associations, their organizations, to be able to bring their voices and to be able to bring their lived experiences to decision-making. And all this leads to better consultation when we're doing program design, better raising of awareness, education, and health literacy at the community, and equipping persons to be better able to make decisions. So what are some of the things then as ACHA we're able to learn from the HIV and AIDS movement, and then be able to look at how do we action for cervical cancer elimination? The very first one is in policy advocacy for change. We know we are only 6 years away from the 2030 targets. We know that if action is not taken now, by 2030, we will be sitting and saying, oh no, how did we miss the deadline? Or how did we not reach what we needed to reach? And it starts from an understanding, both at the policy level as well as at the community level, that we are all working towards a similar goal. Therefore, how do we prioritize elimination for every woman and girl, be it a woman living with HIV and AIDS or a woman who doesn't know her status yet, and therefore could be making assumptions about her health? Secondly, how do we ensure that we can focus on research so that it is able to inform the milestones that we're making, or even be able to inform how we can better integrate our services in our existing healthcare systems, and also improve on the infrastructure that is already serving women and girls in various settings that we have. Secondly, people-centered care interventions. When I was listening to Meg earlier speaking about self-sample collection, as ACHA last year in January, we did some focus group discussions supported by FIND, and these were in the community. Initially, we had trained the community on how to do focus groups, and then we went to the community to ask these questions. And in fact, one of the things that we found out was that this would be a game changer if readily available to every woman, because we're giving power to the woman. She no longer has to ask for permission from her husband to go to the facility to get screened. She no longer has to go and see the nurse, probably who sits with her in other social settings. She can just present her sample, and that sample will be tested, and then she will know her status on cervical HPV testing, and as well as be able to be navigated across the system. And so looking at how we can use research as well as people-centered care interventions to prioritize individual responses, as well as collective, systematic, and planned action towards elimination, where the needs of the community as well as the needs of the healthcare system marry each other, and we get together to be able to make critical decisions for women and girls. And involving them in that journey is all about putting people first. And so you may be asking then, what is ACHA and how are we getting there? If with this slide, I'm just showing you that ACHA is in some of the countries that were highlighted by Meg in terms of the gaps that are existing as well as capacities that are existing. However, we see very many gray areas in terms of the countries that we've not reached. And for us, we know that in Ubuntu, in Africa, all moving together will be able to make so much more difference. For example, ACHA is currently represented in 16 countries. And these countries collectively hold a population of over 693 million people. Secondly, ACHA has 22 organizations currently in membership. We have organizations that have been in existence for over 30 years, as well as organizations such as ACHA itself, that is only 4 months old. That is a wealth of information, knowledge, and expertise. We have organizations that are purely concentrating on cervical cancer, others concentrating on breast cancer, but taking on cervical because it's the same woman. We also have organizations that are working in HIV and AIDS, and at the same time, they're looking at how do we bring the conversation that it's every woman, every girl, no matter where she is in the social strata, no matter what other comorbidities they have, they're all at risk of cervical cancer, and being sensitive that women living with HIV are even at a greater risk by virtue of their immunocompromised status. And so with that in mind, what we're looking at as ACHA is training, capacity building, ensuring that we get all our members well equipped with knowledge that will move the needle forward. For example, just last week, we finished a training, a workshop where we're doing qualitative research methods. And it's strategic because for us, we're looking at some of the metrics that have been mentioned on WHO are already clearly being measured by WHO. But what about the other metrics that are not necessarily being measured? Like, for example, how well civil society is integrated in health literacy. Secondly, we're engaging with civil society because we know that's where the expertise is. These are the people who are having daily lived experiences with women with cancer of the cervix, women with breast cancer who don't know that they need to be screened, women living with HIV and AIDS who have already mechanisms for screening, but that not necessarily utilizing them, and women in the community who don't know their HIV status, but should be equipped to know so that they also know how much of a risk they also bear with cervical cancer. And so with that in mind, just to give you a snapshot of the areas of collaboration and potential working together that we could work together with yourselves all. And we have 5 work streams, but these for us are informed by putting communities and people first. We are looking at in advocacy and research, being able to generate data that can be utilized in decision-making, but at the same time to poke holes and show gaps in service delivery that is already existing. Secondly, in capacity building and training, that our members can be able to put their voices forward in their different countries, but also collectively we can show where Africa is in the elimination pathway. Thirdly, in demand creation, for example, we know in community engagement and outreach, our members are reaching at least 1 million persons face-to-face in our outreach model in the various civil society organizations that they are working with. And so for us, we're looking at how do we harness that capacity? They're already working in the community. What can we do together to make sure that demand is created and outreaches are done to demystify the disease and showcase capacities of integration? Fundraising and resource mobilizations, I had Meg mention that in policy advocacy, one of the calls to action is investment for elimination. And this is critical to move the needle by 2030. So how do we ensure this is happening? Lastly, in communications and materials, we know that information is power, but only if it is utilized. Otherwise, it becomes just knowledge that is sitting in people's heads. And so we are looking at standardizing communication because we know the challenge is one, cervical cancer. The interventions are available, HPV vaccination, early detection and screening for early detection and timely diagnosis for treatment and access to treatment. If we can standardize this, and we are working on it, then we can be able to make sure that we integrate including HIV and AIDS messaging, and so that we can all work together. The 2 disease areas need not be mutually exclusive. Resources that are being channeled to HIV and AIDS interventions can also be channeled towards cervical cancer interventions across the countries that we are serving. And so with the last call to action, let communities lead, my ask of all of us is to think, how do we allow communities to harness their passion, their purpose? Most organizations are usually formed by people with lived experiences that see the need in the community and want to make a difference in these communities. How can we harness that passion and purposeful dedication to elimination, coupled with resources that we inject into the society so that we can be able to have long-term, agile, inclusive response to the HIV and AIDS, as well as cervical cancer challenge that faces us today? Thank you so much for your time.
Thank you so much, Benda, for really, highlighting the crucial role that communities play and for that very inspiring sharing of the work that you're doing on the ground. Amazing. Thank you. Next, we have Karen Canfol, who's the director of the Daffodil Centre, which is a joint venture between Cancer Council New South Wales and the University of Sydney. And Karen is also a professor and NHMRC Leadership Fellow of the Faculty of Medicine and Health at the University of Sydney in Australia. Thank you, Karen, for joining us at this late hour from Sydney. Over to you.
Thank you so much, Prof. Adiba, and thank you very much to IAS and partners for the wonderful opportunity to speak today about this critical area in the health of women and people living with HIV. And I'm going to talk about, building on that absolutely brilliant talk about the role of community engagement and civil society, I'm going to move to the importance of also building the investment case for investing in cervical cancer elimination. And this is just my disclosures, which are investigator-initiated programs of work. So we've heard today already from Dr. Doherty about the 3 pillars of cervical cancer control, the 90-70-90 targets. If implemented, they're stretch goals, but if implemented by 2030, they will get us to elimination of cervical cancer as a public health problem, or rates so low it will be considered to be controlled, less than 4 cervical cancer cases per 100,000 women per annum. But what's less well understood perhaps is that there's not just the impact case, there's also a major investment case for countries to invest in cervical cancer control. The WHO global strategy to accelerate the elimination of cervical cancer as a public health problem has also presented, on average, the return on investment across low and middle income countries is that for every dollar invested, US $3.20 is returned to the economy. And this rises to $26 when the wider benefits of women's improved health on families, communities and societies are considered. Now that's on average, and that's in LMIC. And I think that's incredibly important to keep in mind as we deal with our governments and we deal with departments of finance as well as departments of health in presenting the case for this investment. Now, the original WHO strategy was supported by comprehensive modelling across 78 LMIC. And you can see this picture of cervical cancer incidence rates in the year 2020, very much the picture that you've already seen. This is in LMIC, these high rates in red in sub-Saharan Africa in particular, to some extent in Latin America, and also in the Indo-Pacific region. Those are really the 3 hotspots, if you like, in the world. And really the case for cervical cancer elimination was based on this global modelling. I'm going to show you a simulation now. As the ticker goes up on the left, you see if countries can scale up to 90, 70, 90 targets, then rates will begin to drop within the next few decades across all countries and reach that desirable navy blue, which is less than 4 per 100,000 women per annum. And on the left, you can see the average elimination year by region, but essentially the good news is that across East Asia, South Asia and the Pacific, the elimination on average will be achieved potentially by 2060 to 2070, and in sub-Saharan Africa by the end of the century. And the difference is because of the difference in starting burden of disease, but really critically, every country in the world can eliminate cervical cancer if we take action today. Now, it's not just elimination as an end goal. That's obviously a desirable end goal, but it's actually, of course, about the lives that we save along the way. And this is a different way of looking at the same data, but now we're talking about cervical cancer mortality rates. So this is now an age standardized rate. So if we do no more, we'll have this same high 14 per 100,000 women per annum. If we implement girls-only vaccination, you can see that rates will drop, but it will take several decades. It's when we combine vaccination with screening and cancer treatment scale up that we see this incredible rapid drop. And this purple line here is the elimination strategy, twice lifetime screening, cancer treatment scale up, and investment in prophylactic vaccination. If we can achieve this, it will be lives saved in the short term, up to 400,000 lives by 2030, 14.6 million lives saved by 2017, the next half century, and over 62 million lives averted over the course of the century. So that's the promise of investment in cervical cancer elimination. So let's move particularly now to the second pillar, HPV screening, because I think it's here that there's been some critical work that has needed to be done and has been done just in the last few years to support this work on elimination as a whole. Now, as Dr. Doherty mentioned, I think a really critical development was the launch in 2021 of new revised guidelines from WHO, the 2021 Screen and Treat Guidelines, which provided new models for the implementation, particularly of primary HPV screening in LMIC. And these are now living guidelines, evaluating new triage technologies, for example, and new technologies as they emerge to keep these guidelines current and living. But the critical change since 2021 has been that WHO now unequivocally recommends using HPV detection as a primary screening test rather than VIA or cytology, that's visual inspection with acetic acid, for both the general population and women living with HIV. And this slide shows you very briefly some of the data and evidence sitting behind that recommendation. This is a couple of recently published modelling papers that really show the average lifetime trade-offs, the benefits, the harms, and the cost effectiveness of different ways of screening. And really the key point here is that it supports HPV primary screening as far and away the best trade-off of benefits to harms and the most cost-effective approach to screening in the general population and for women living with HIV. And that's a really important take-home. Now, by cost-effective, what we mean is that this screening approach gives bang for a buck. It delivers results in terms of lives saved for every dollar spent. That doesn't mean that today HPV testing is yet accessible and affordable, and this must be a priority. I think that one silver lining, perhaps from COVID, may be that there is now increased capacity to conduct HPV testing in many countries. And this is just an example in the Pacific Island countries, showing a 54% increase in point of care gene expert instrument numbers across these territories because of COVID, which of course can now be redeployed as testing for HPV in programs. Recently, there's been an important effort led by Unitaid to survey the landscape for HPV testing and other relevant screening, triage, and treatment technologies. Really critically, it's looked not only at the availability of HPV test technologies, there's more than 250 tests out there, but it's really looked at which of those tests have market authorization and also have clinical validation, really critical to ensure quality, reliable testing. And there are the preliminary results suggest that there are now 18 tests for primary screening with HPV technology that satisfy these criteria. And of course, we hope and expect that this will increase dramatically over the next couple of years. WHO is developing target product profiles for such tests, and it will be very important as new manufacturers enter the market to help with market shaping, to increase the affordability of the test and provide more options to policymakers. So that's, I think, a really important aspect of building on the work that's been done in terms of HPV screening. I just want to finish with a few words about how the investment case can be really important in our global implementation efforts, and talk very briefly about a landmark investment that's been made in elimination of cervical cancer in the Western Pacific. This is a philanthropically funded program of work from the Minderoo Foundation, which focuses on scaling up to 90-70-90 targets in the Western Highlands of PNG and the Pacific Island nation of Vanuatu. And the idea with this program is to screen whole, entire age-eligible cohorts of young girls with HPV vaccine and screening with HPV screen, triage and treat as appropriate for older mid-adult women. So this has been a wonderful demonstration of concept. To date, around 20,000 women have been screened, for example. And just to show this recent launch of the elimination program by the Vanuatu Ministry of Health, this was in October 2023, and really showing that country engagement and leadership in the new programs to achieve elimination. This has been supported by data and evidence, and it's really critical I think, to localize that modeling evidence for the investment case for a country. So here's some results from a new elimination planning tool that we're piloting that brings the power of that modeling and that financial investment case to countries. This shows, for example, that Vanuatu could eliminate cervical cancer somewhere in the region 2050 to 2054, and could in fact potentially be the first LMIC to do so. And this has been a really powerful driver, a really important driver of the investment case and ownership by the incredible leaders in Vanuatu. So just to finish, I will say that this program is now being built on, and we were recently delighted that the Australian government has announced a major investment under their Partnerships for a Healthy Region initiative. And there are many Australian and international partners with the logos shown on this slide. But this is a major regional aid grant across the Indo-Pacific, which will build on the current work. And it will really leverage these long-standing local, regional and international partnerships to accelerate the elimination of cervical cancer in the Indo-Pacific using a country-led co-designed implementation footprint. And there will be 6 priority areas of work. There will be focus on strengthening primary prevention through HPV vaccination. There will be focus on improving secondary prevention through implementation of HPV screen and treat and screen triage and treat. There'll be a focus on improving secondary prevention with laboratory strengthening and histopathology strengthening. There'll be focus on building capacity for digital health registries to support screening programs as well as vaccination programs. There will be support for building strengthening cancer treatment services and access to palliative care. And there will be support for building the financial case and for engaging and strengthening civil society activity. So just to finish, we have, of course, February is World Cancer Day month. We've just celebrated World Cancer Day. This year, the theme was Close the Care Gap. Where you live shouldn't determine if you live. And of course, one of the major recommendations in UICC's major equity report released 2 weeks ago was to continue to implement programs for the routine screening of common cancers, particularly HPV and HBV, as well as provide evidence-based screening programs where they exist. These are the most effective and cost-effective ways of controlling cancer more broadly. So it is now 3 years since the launch of the elimination strategy. It's an important moment, I think, to recommit to that strategy and to investing in cervical cancer elimination for women and people living with HIV. And with that, I will thank all my many collaborators in the work presented here, and thank you very much for your kind attention.
Thank you so much, Karen, for that brilliant presentation as always, and making that important investment case so that our finance ministers in our respective countries will come with us on this journey to eliminate cervical cancer. Okay, I've just had a notice that we need to move on because we are running a little behind. So our next speaker is Helen Kelly, who's a consultant epidemiologist at the Department of HIV, Hepatitis and STI at the WHO. And her work focuses on the integration of cervical cancer screening and treatment and HIV prevention and treatment services. So Helen.
Thank you very much, Adiba, and thank you to IAS for giving us this couple of minutes to speak on this topic. I'm just going to try and control screen now. Apologies.
You just click to take control.
Sorry, it's not working there. So perhaps I could ask Julia to move the screen for me, please. Thank you. Next slide. So over the next 10 minutes, you can continue pressing the click to the end of the slide, please. Over the next couple of slides, I'm going to present some information focusing on that second pillar towards elimination, which is screening. And at the WHO last year, we organised a meeting to understand the operational considerations for rolling out cervical cancer screening for women living with HIV. But just to give a background on the importance of screening in this population, as we've heard from the earlier presentation from Meg, women living with HIV have an increased risk of persistent infection and the associated cervical cancer compared to women without HIV. However, effective antiretroviral therapy with sustained HIV viral suppression does reduce that risk, and that underlies the importance of maintaining effective ART in this population. We do know in high income settings over many decades that high quality screening and treatment programs are largely effective in reducing cervical cancer incidence over time. And in particular, among women living with HIV, recent modelling evidence has shown that enhanced prevention strategies, including both HPV vaccination and frequent screening among women living with HIV, is really important in reducing cervical cancer incidence in this population. At the same time, women living with HIV are attending specialist services through accessing their antiretroviral drugs and monitoring their HIV disease. And we know from recent monitoring data through Unitaid that 82% of women and girls 15 years or older are receiving ART through clinic or community-based services. And 76% of those have suppressed HIV viral loads. So we know there's a large population of women and girls living with HIV accessing HIV services. And this HIV care infrastructure provides the opportunity to introduce and integrate cervical cancer screening and treatment with regular follow-up. At the same time, we still don't have a good understanding of the coverage estimates of screening and treatment in this population, though we are doing some work on this. But we do know from preliminary data that women living with HIV have an increased risk of ever having a cervical cancer screening event in their lifetime. And this is likely because they're accessing these services and cervical cancer screening is being integrated within those services. Next slide, please. So in May last year, the WHO organised a think tank bringing together members of ministries of health, HIV, cervical cancer programme managers, as well as cervical cancer HIV advocates and members of civil society, in order to understand better what those operational considerations towards introducing screening and treatment within HIV care are. So we aim to document the different models of service delivery, but also hear from countries about the successes, challenges and lessons learned. Next, please. And the main themes that was discussed in this 3-day meeting were around the introduction and scale up the experiences around that for HPV DNA testing, the role of self-collection in increasing access to screening, retention of women in the screening, triage, treatment cascade, and then also to hear about how monitoring and evaluation was being conducted. Next slide, please. So in terms of the models of service delivery, we heard a wide variety of models of care, and this tended to depend on the HIV prevalence in that setting or country, the geographic setting, whether it was urban or rural, and whether there was an existence of donors or implementers in those settings. So broadly in 2 camps, we heard experiences of cervical cancer screening that were fully integrated in HIV clinics, but then equally in cases where women living with HIV may have been referred to other services where women not living with HIV could also access cervical cancer screening and treatment. Next, please. VIA was the most widely reported screening modality by the participants at that meeting, although there was some experience of HPV test introduction with VIA triage of HPV positive women. There was some experiences with self-sampling, and where HPV DNA test was used, we heard different experiences using centralized approaches through existing lab systems or decentralized hub and spoke models. Next, please. Thermal ablation was the most common treatment modality reported, but we also heard of experiences with cryotherapy as well as LEDs. Next, please. And then in all settings, incremental increases were being reported in cervical cancer screening coverage. although participants mentioned further challenges further scale up requires overcoming some of the challenges. We talk about these in the next slide. Next, please. So in terms of introduction and scaling up of HPV DNA testing, we heard from meeting participants that this is early experiences have reported that costs of HPV DNA tests and the infrastructure needs can be challenging. However, the integration of services within HIV care provides opportunities for increasing system efficiencies as well as cost savings. And this is because of the existence of laboratory systems for HIV plasma viral load, CD4 count, and others, and the establishment of guidelines on multi-disease testing. The existence of existing human resources within clinics, as well as established referral networks, both for the samples from clinic to lab, but also the communication of test results from lab to clinic to patient through lab management information systems. But there were reported challenges with capacity and availability of these multiplex test platforms. And in some cases, HPV testing may be deprioritized when other testing is occurring. Next, please. And next to the end of the slide, please. Thank you. So for self-collection for HPV DNA testing, we heard that also through the talk from Benda that self-collection is more acceptable to women, easier to collect. It provides that feeling of empowerment for women, which is really important. We also heard that it's acceptable to healthcare providers. It's feasible to introduce within HIV clinics, and also saves the time of those healthcare providers that may have been organising and conducting visual inspection exams. Established infrastructure is available to collect and transport samples and communicate results, perhaps through existing HIV services. We also heard some interesting experience from Malaysia on their use of temperature-stable flock swabs, which allows for community-based screening and improving access to hard-to-reach settings. And this also allows batching of samples and facilitates outreach campaigns. A unique consideration when we talk about increasing access for women living with HIV is the innovations in delivery of ART and differentiated service delivery, and how HPV self-collection can be introduced within this context for community-based models of care. But participants noted it's really important in these situations to plan quantity of tests, but also the turnaround times for results and strategies to communicate the results back to women. And at the time of this meeting, we had no full experience of understanding how well this was being conducted or some of the challenges associated with that. And because women living with HIV require that additional triage step, it's important that referral systems for the screen positive women are implemented where self-sampling is being used. But quite crucially, the engagement and participation of communities was cited as highlighted as being important in generating the demand among women in the community, but also rolling out self-collection and ensuring that linkage to follow-up care. Next slide, please. And next. So in terms of retaining women in the screening triage treatment pathway, again, the existing HIV infrastructure was cited as a useful opportunity to retain women and engage women throughout the pathway, but there's still challenges in same-day triage and or treatment where the HPV test is being used and it may not be returned during that same visit. However, participants mentioned the importance of having a systems-based solution or the opportunities to align the cervical cancer screening, triage or treatment visits within the ART visit schedule. That requires a well-established appointment system and also comprehensive data collection and reporting, and this was cited as an important retention tool. Again, the established civil society organisations were highlighted for peer navigation, and women with lived experience and survivors of cervical cancer were also provided their experiences on engaging with women in creating that awareness and education on understanding the screening, triage and treatment pathway, and the importance of engaging with that. Next slide, please. And then in terms of lastly, data needs for monitoring and evaluation is an important fourth pillar in achieving cervical cancer elimination. And we now have these consolidated guidelines on person-centered HIV strategic information. And within those guidelines, screening and treatment for cervical cancer is recommended and should be recorded in routine HIV reporting systems. These existing HIV reporting systems provide an opportunity to monitor progress towards increasing coverage of screening and treatment for women living with HIV, but also monitoring the impact on clinical outcomes ultimately. The established monitoring systems in HIV management for patient management and programmatic evaluation were cited as opportunities in terms of well-established appointment systems supported by comprehensive data collection and reporting. Some issues were cited in terms of interoperability of data systems and perhaps the identifiers to link women in the cervical cancer registries with the HIV registries may be challenging. However, we heard of experiences in some countries where they conducted national data workshops with the relevant stakeholders to try and find solutions to some of these issues. And we also heard about the harmonisation of monitoring indicators where there are multiple actors providing cervical cancer screening and treatment services within a country that users are able to report on the same indicators for monitoring ultimately in the long term. Next slide, please. And so just to summarise, integration of cervical cancer screening, triage and treatment is feasible in HIV treatment services and provide opportunity to increase access among women living with HIV. Monitoring coverage is important towards achievement of cervical cancer elimination. And this is from the point of view of understanding better the introduction and scale up of programs for screening, triage and treatment, but also the frequency of screening for women living with HIV, because we do know that women living with HIV should have the opportunity to be screened frequently. And ultimately, we would like to be able to evaluate the impact of screening and treatment programs on clinical outcomes such as cervical precancer and cervical cancer. And long-term sustainable approaches are needed to ensure the continuity of these programs. And lastly, the importance of the engagement and participation of civil society are crucial in achieving ultimately cervical cancer elimination in this population. And so with that, I thank you and back to you, Adiba.
Thank you so much, Helen. And we've heard the importance of trying to achieve this integration, particularly in high disease burden countries. And moving along, we will hear from Doreen Ali from the Ministry of Health, Malawi, who will share with us exactly how Malawi approaches this cervical cancer prevention and as a model of service integration. Doreen, over to you.
Yeah, good morning and good afternoon. This is Malawi, just presenting the approach of Malawi on cervical cancer, secondary prevention, the model for HIV, cervical cancer services integration. So I'm going to talk about integration, how we are integrating the two as Malawi. Next slide. Next slide. So for Malawi, we have got 150,000 people living with HIV, and our HIV prevalence is twice as high among women compared to men. And the cervical cancer estimates, according to GlobalCom 2020, total new cervical cancer cases is at 4,145. And for total deaths due to cervical cancer, we are at 2,905. And the age standardized incidence rate for cervical cancer is at 67.9 per 100,000. And the age standardized mortality rates at 51.5 per 100,000. And approximately 43% women living with HIV screened for cervical cancer by 2021. On our timeline for key CCAP milestones, In 2004, we had a national Zika program established in the country. And in 2005, we had a cervical cancer, which was included in the essential health package. So that was aligned with the health sector.
Deepa, I think
Sorry, we've lost Doreen. Yeah.
Doreen, are you still there? We might need to move to the next presentation and come back to Doreen, I think.
Yes. Doreen, are you there?
Yes, I'm here, but I think I don't know what happened.
Okay.
Our slides went missing.
Okay, so maybe we go back to Doreen's slide. Doreen, it could be a bandwidth. Maybe we'll just have to
Maybe you
listen
can
to your voice.
turn off your camera, Doreen.
Okay.
Thank
Yeah,
you.
and we'll put your slides
you.
back up to
Okay,
where
thank
we
you.
were before.
So I continue.
And participants do bear with us for a short while. Yeah, please go ahead.
Okay, so in 2020, HP vaccine integrated into the routine immunization. So that was in 2020 where the integration happened. And in the same year, Malawi committed to the WHO cervical cancer elimination agenda. And in 2022, there was launch of the revised cervical cancer strategic plan. So we have a new plan from 2022 to 2026. So in 2018, cervical cancer screening and treatment was integrated into the routine RT services, and where cervical cancer screening and treatment services are provided to women living with HIV in the same room, mostly through referral to the cervical cancer clinic. And the cervical cancer messages are also integrated into routine client counseling provided by our providers. And almost all IRT providers have received training on cervical cancer screening and pre-cancer treatment. And most of the RT clinics have thermal ablation devices to ensure same-day treatment for eligible VI and plus lesions. And also the RT clinic volunteers and expert clients conduct demand creation and sensitization at the facility and also in the community. So our client flow is as follows. Once the client is there, so every client coming to the ART clinic, either new or on a follow-up, is offered cervical cancer screening information and service. After health talks client education, our clients are offered cervical screening before proceeding to access ART services. And then in facilities doing HPV testing, the HPV sample is taken soon after client education and sent to laboratory to ensure result is ready before the woman leaves the facility. So it's it to be done there and then. A unique identifier color code is put on a client master card. So this is used to identify their subsequent visit for provider to know whether the client is due for screening or not. Integration opened, this is for us, we call it a best practice because integration opened opportunities for financing. So funds are leveraged from PEPFAR and the Global Fund Investment for HIV. So we have PEPFAR, supporting facilities on training, mentorship, and supplies. And also for Global Fund, they are supporting procurement of the technical assistant and also the LIP devices. And also the HPV test. And for Unitaid, we are supported introduction of the HPV testing, so including self-sampling, procurement of TA, and also LEAP devices and capacity building of providers. For health sector joint fund, we have 200. We have this funding which we pledged for training of providers and also mentorship and review meetings for this year. So we also expanded screening services from 81 to 475 facilities between 2019 to 2023, and also increased in access to cervical cancer screening for women living with HIV. 30% of all women screened in 2019 were women with HIV, living with HIV, and this has also increased from to 64% in last year. Treatment coverage for precancerous lesions increased from 36% in 2019 to 49% in 2023. So we are really making good progress on this. So what has been the path to elimination? Or the 90, 70, 90 targets. So on the HPV vaccination, for the our target is 100%, as you see on the graph, and we are at as now we are for the 2 doses, first dose and second dose, we are at 55.1%. However, with the new WHO guidance only having only 1 dose, this coverage will increase further. On screening, our eligible women target is at 100%, and now the total women that have been screened is about 40%, and on the total total population with positive test outcomes is about 4%. And for the cancer suspects, we are at 1.2% on this subset. These suspects are from the facility level and are the ones referred to the tertiary level. For the treatment, our target, as you can see, is at 90%. However, total treated was at 42%. And on the same day treatment is at 32%. And for the ones that we treated, the 42%, these are those
Doreen, we've lost you again. You back?
Yeah, I'm back.
Okay.
Yeah,
I
so the
think you
42% are those
connected.
treated at the tertiary facilities. That's inclusive of the cancer suspects from the facilities. So this overall, this is our path to elimination for the 90, 70, 90 targets. We are still working hard to really achieve that. We also have some challenges that come with it. So we have several challenges, as I highlighted from this slide. The first is lack of funding, where we have the cervical cancer secondary prevention services are only available in 60% of the target facilities, and only 18 facilities provide HPV testing. So you can see how we are faring on that. And also lack of training and mentorship for providers. So we have not mentored all of them. So we are still providing the mentorship and training for the providers. And inadequate human capacity, lack of resources to build healthcare workers' capacity to provide specialized services like the race treatment and the gynecology surgery. And we also have issues of, challenging with the data system. So we need to really focus on the data. And I saw from the previous speakers, they also mentioned on the same the data systems. We also have issues of lack of awareness and cultural society factors. which lead to poor health-seeking behavior, leading to delayed presentation, and also poor pre-cancer treatment rate due to society factors. For example, women have to consult their husbands before they come for thermocoagulation, because it takes a while after they have to heal. So the husbands, they are very they are concerned with this fact. And the other issues are loss to follow-up. Stem cell result delivery is challenging in HPV testing, leading to high loss to follow-up, and also lack of strong system for patient tracking. So once they are lost, it's difficult to get them back to care. The other challenge is poor tertiary care, where there's lack of radiotherapy services. We don't have that at the moment. Maybe in the near few months, we are going to have some radiotherapy services in country. Limited pathology service with a long waiting time. So we have to wait a long time. And few of them are chemotherapy drugs that are available in Malawi. However, we have still working out on how we can overcome these challenges by strengthening integration of the cervical cancer services in existing services, and also go through to reach the communities through the outreach clinics. And also we want to increase demand creation to reach rural communities for early screening, because that's where we find that we need to do more prevention through counseling. The men too, they need to be part and parcel, because if we only include women, we have issues culturally. Also, we want to explore other low-cost interventions on how we can screen women, for example, HPV testing, and also to ensure that maybe we have to reduce the waiting time, because waiting time is also an issue for our clients. And as I've indicated, we need to embark with our civil society to support us at the community level, rural communities, to really involve the men as male involvement, as I have indicated earlier on. Otherwise, for Malawi, this is what we are doing on integration. Thank you.
Okay. Thank you very much, Doreen. Moving right along as we are running out of time, Maribel Almonte will speak to us on the importance and how to improve access to HPV testing. Maribel.
Thank you very much. I think we have very short time, so I'm trying to be as brief as possible. Just waiting for this to move. It's not moving. Just a second. Okay. So I'm Maribel Almonte. I'm an implementation scientist working for the Cervical Cancer Elimination Initiative, which is now sitting on the Department of Non-Communicable Diseases, Rehabilitation and Disability of the World Health Organization. So we've heard from my previous predecessor speakers that we have 3 pillars for the elimination, and I'm going to focus on the second pillar, but without forgetting that to reach the 70% women screened with a high-performance test also implies that we need to reach 90% of women with identified cervical disease being treated adequately. In WHO, we have some strategic actions shown here. And the most important ones are that we are promoting simple screening algorithms that you've seen before as well today that come from the 2021 WHO guideline. We want to understand the barriers and to enable an environment for screening, particularly improving communication and information to avoid further stigma, as heard as well today, and to ensure affordable supply of quality-assured high-performance screening tests and treatment devices. This, when we talk about HPV, will also need to have good laboratory infrastructure and screening services capacity. And of course, as mentioned in the talks before, we need to integrate the screening and treatment services into primary care and into other programs available in countries. So talking or focusing on these 70% and 90% of women treated once they are HPV positive, our role is to ensure affordable supply of quality assured, high performance screening tests and treatment devices. And to do this, we are working on different fronts. The first one, already mentioned as well, the living systematic reviews and recommendations to quickly update the guidelines released on 2021 according to evidence that is accumulated on novel technologies that come into the market. The second point is to work, we've started to work on the target product profiles for HPV screening tests. And the third one that is under planning is to actually conduct some dialogues with the private sector in order to open, further open the market and giving more options to countries when dealing with HPV test procurement. So talking about the living systematic reviews and recommendation, it's just to mention that we think that decision makers should not wait long to update or to change, the routine practice or to implement a new guideline according to the evidence that come up. And this is why we have this process by which we try to be more efficient on evaluating, monitoring and evaluating the evidence that come up with regards to cervical screening and treatment. In December 2022, we have the first meeting of the Guideline Development Group, and the group actually highlighted 5 priorities, which for further monitoring and evaluation of evidence, which are actually the HPV extended genotyping, implementation approaches for HPV cell sampling, different screening and treatment techniques for women living with HIV, artificial intelligence for visualization of the cervix, and the evaluation of potential point-of-care tests. And we decided afterwards, as we are evaluating and monitoring this, and you will hear more news in the coming months about our evaluations, that we needed to focus on the HPV target product profiles. And we have started this work, it's almost completed, and we had a meeting last year to actually complete the first version of this. What is a target product profile for you who are listening this for the first time, or a TPP? It's a document that actually indicates the product characteristics of certain products to meet a global health need. So WHO TTPs guides and coordinate the development of new health products with clear product characteristics, considering the populations, the access, and the equity from the point of development of the new product. And so a TPP aims to incentivize research and development for priority health products of public need. A WHO TPP is a WHO-led process, and I think that is important to remember. This shows you what we do when we actually go through a TPP. We identify the need, we define the scope, we develop the TPP, and we finalize with a publication. In our case, we decided to focus our TPP for HPV screening tests to detect cervical precancer and cancer. And so we are now in this point, in the developed point, and we have actually completed the first version of our TTP, and it's now in public consultation for 28 days. So you will see what has happened is that our working group of 39 members, very balanced across regions, with a lot of expert stakeholders, women's representatives, we decided to go on and do 2 types of TPPs, one for HPV laboratory testing and one for point-of-care testing. And all of this has different domains. We have 36 sets of minimal and preferred characteristics, which is the way that we look at the parameters that a new product for HPV testing should have. And one of the most important results so far is that self-collection was considered as a minimal characteristic for any future test. And then, this is what we focus ourselves. We also discuss heavily on genotyping spectrum, whether we want to test with 2 types, 8 types, 12 types, etc. What will be the result output? Do we want positive, negative, or do we want different results, HPV-16 positive, HPV-18 positive, etc.? And particularly, we discuss a lot about the cost. And what we heard so far in this webinar is that the cost is really a great challenge for all our countries. So now we are at this step. We have the TPP's version 0.1 for the 2 types of testing, and we are under the public consultation, and you will get the link for this public consultation. Anybody can actually go into this webpage and give us comments and ask questions so that we actually refine the product that will be published after this public consultation. So the next step that we are working, or we are going to start working, is in the private sector dialogues, with the aim to strengthen commitment and contribution of the private sector to increase access to HPV tests. So our TPPs are guiding manufacturers as to produce or as to develop products that have public health impact and that actually responds to the needs of our countries. But further on, we want to discuss with them what we really need for this global implementation of HPV screening and to reach our 70% coverage. So this is very connected to the target product profiles that are going to be published in about 2.5 months. That's how long it takes. And on the evaluation of novel technologies from the living guidelines. So, but we are also doing other coordinating activities, such as collaborating with different stakeholders to support clinical validation of new HPV tests, those that have, some potential to actually be used in our countries. And also we work together with the WHO pre-qualification team to actually support each other for trying to address new aspects of the pre-qualification for HPV tests, such as self-sampling devices, for instance. And soon we will get a new protocol for evaluating HPV tests that actually allows self-sampling. So in summary, I want to say that we want to support countries' efforts to implement and scale up HPV testing to reach the 70% screening coverage elimination target. We have 3 things that we are working on, and you will hear very soon from us all the results. The living guidelines, soon we will have by December, you should hear from us with new recommendations, the TPPs, which actually support, new tests in the pipeline, and the current HPV tests to undergo improvement, and the private sector dialogues that we are trying, to even further open the market and get better prices or better tests, affordable and available tests for all our countries. Thank you.
Thank you so much, Maribel. And moving right along to Andrew Grulich, who is an IAS Governing Council member from the Kirby Institute in UNSW in Sydney, Australia as well. And Andrew is going to speak on the other component of HPV-related cancer, which is anal cancer, also a major concern in people living with HIV. So, Andrew.
Thank you, thank you, Adiba. Good evening to everybody from Sydney, Australia, and thank you very much to the organisers for agreeing to have one speaker talk on another HPV-associated cancer that is a really major issue in people living with HIV, and that is anal cancer. And there have been some developments here that we really wanted to bring to your attention. Okay, so just this brief presentation, and thank you for staying a few minutes. I will be brief on some new findings in this field. So the major new scientific finding over the last year or so has been the first ever evidence that actually treating anal cancer precursors reduces anal cancer risk. And this was in the large anchor study in the United States, published in the New England Journal. More than 4,000 people living with HIV who had high-grade anal dysplasia were enrolled in the study, randomized to either ablation or active monitoring without treatment, high-resolution anoscopy every 6 months, followed up for about 2 years with nearly a 60% reduction in anal cancer incidence. And this is a finding which has really energized the field, because for the first time we have high-quality evidence that treating anal dysplasia reduces cancer risk. So the other major advance, and this is published only in the last month, has been the first of what are anticipated to be a series of guidelines for anal cancer screening. And these are from the International Anal Neoplasia Society, which got together a working group with representatives from around the world, really the top players in the field, to come up with the first set of guidelines. And I will say that we're also anticipating guidelines from the US Centers for Disease Control in the near future. But the ones I'm showing you today have just been published in the last month in the International Journal of Cancer. And looked at really 2 questions: who to screen and which screening test to use. So the question of who to screen was based mostly on this recent meta-analysis published in 2021, which looked at anal cancer incidence rates in people with HIV and people who don't have HIV, in men who have sex with men, in women with gynecological precancer, and in other forms of immune suppression. And color-coded on this figure, with the red being higher than the yellow, being higher than the blue, are the anal cancer incidence rates. So the highest rates of all in HIV-positive men who have sex with men, but also substantially increased rates in other men with HIV and in women with HIV. So this is an issue across the different risk groups of people with HIV. Also, women with previous vulval cancer are at greatly increased risk, and organ transplant recipients who have been immune suppressed for substantial periods of time. So looking at all of these incidence rates, the working group fairly arbitrarily chose this threshold of screening people who had greater than tenfold the background population risk of anal cancer, which is equivalent to 17 per 100,000. So certainly more common than cervical cancer in the general population. And in many of these, the rate is much higher. So based on this cutoff, this does lead to different age thresholds for recommended screening people with HIV, starting at 35 in men who have sex with men and transgender women with HIV, but 45 in other men with HIV and in women with HIV. But it is recommended that in these guidelines that all people with HIV should receive screening, and also screening recommended in women with vulval high-grade disease or cancer, and people who have had a solid organ transplant and are receiving immune suppressants. So the other area investigated with less definitive recommendation was which screening test to use. And unfortunately, because until now, this has only been conducted in a few research sites around the world, there is not yet universal agreement. Anal cytology can be used with a referral threshold of any abnormality, but when you use that level of threshold, you get acceptable sensitivity, but rather poor specificity. High-risk HPV testing, as in the cervix, gives better sensitivity, so close to 100% sensitivity, but the specificity is a real problem and is too low for practical use. And what this means is that you get very high referral rates, and when we don't have much infrastructure at the moment, this is a major problem, and we really are in need of biological triage tests, which would increase the specificity in identifying high-grade disease in people who test positive for high-risk HPV. A number of these are under active investigation. None of them are really standouts at the moment. I think I pressed that forward. Okay, so just as a final slide to wrap up, I really want to emphasize the exciting news that there is change in this field. We now do have expert guidelines recommending anal cancer screening and treatment of high-grade disease in people living with HIV. We are stuck at a bottleneck, though. We have a huge lack of infrastructure in performance of high-resolution anoscopy for diagnosis and treatment. So we're at a stage pretty much everywhere in the world where capacity building is critical. We need health system funding for training clinicians and for clinic infrastructure. And once we start getting that, we need to initially target those at the very highest risks. You will have seen from my data that there's a lot of areas that we don't have definitive answers, and we need a lot more research to improve those screening and treatment methods. But the guidelines, I think, are a real foundation for the future, a real foundation for advocacy and for funding and for research and expanding the infrastructure. And that will be supercharged if, as expected, we get CDC guidelines published soon, which also recommend screening. So there's a very quick overview, and I'll hand back to Adiba. Thanks.
Thank you, Andrew, for that great overview of a disease that we need to hear more about and how to prevent. Mary, I am so sorry that we've run out of time. We won't be having you moderate a live discussion with our panelists. For those of you who can stay, I encourage you to stay to hear from Sally Agalo Kuenda, who will share with you her lived experience with cervical cancer. Thank you, everyone.
Good morning, good afternoon, good evening, depending on which side of the world you are in. My name is Sally. I will request that I don't use my videos. I'm having challenges with internet. So mine is just to say that I've a lived experience from HIV. I was first diagnosed in 1999 with HIV, and unfortunately I got the human papillomavirus, and I was diagnosed with cervical cancer stage 2 in 2007. And because I survived, I decided that I will be a patient advocate, advocating for early screening, especially for women living with HIV. And I'm so happy that this webinar is not ending without one of us speaking, and I'm happy to represent people living with HIV and women also who have gone through cervical cancer. So I wish to remind us about the importance of client perspectives and the need for integrated healthcare services, particularly for people living with HIV. But first, I would wish to commend the great efforts that have been made to manage and contain HIV. Let us remember that meaningful involvement of people living with HIV is key, as we are the shoe wearers and therefore understand better where it pinches. There's no way you can talk about my shoe and I'm the one wearing it. Integrated services save the client a lot of time, as they can quickly attend their appointment and still report to work on time. The cost of transport from one facility to another is also saved, because there's no need of getting ARVs and then I run to another facility for the screening of cervical cancer. So we find that also appointment frequency is reduced. For instance, in my case, I only have 2 appointments per year, unlike before when it was monthly. So we are seeing a lot of improvements in this. So this has meant that there is improved continuity of care, better coordination of services, and more personalized care, and so on, and hence improved quality of life and health outcomes. So just to share a bit on the advocacy work that I do, and so the heart of treatment or care is not just about medical reporting or public health analysis, which of course is good, but for me it is stories. It's my voice. My voice is the strongest tool that I have, and I therefore use it to speak in various forums like I'm doing now, to any audience that is willing to listen. I would like to share a highlight of this past week that I was called to speak to 170 youth in a facility where I get my ARVs. And out of the 170 youth, they were between ages 18 and 26. And 12 of them voluntarily got screened for cervical cancer. And can I say fortunate or unfortunately, but 2 had precancerous lesions, which were sorted out immediately by thermoablation. So we all deserve access to effective treatment for HIV, opportunistic co-infections, and for comorbidities, but affordability is still a concern. I've seen so many patients dying not because of the diseases, but because of the cost of the treatment. So the total cost of treatment is doubling every few years and becoming more and more scary to clients. And that is one of the reasons why we find a lot of people fearing even to go for the screening. They say, I'd rather die of something I don't know. It's because of the fear of the screening. And so I say again that my area of focus in advocacy is my voice. So I'm looking forward to a day when we'll all have to hear this, we'll not have to hear all these terrifying stories of unaffordable treatment costs. I like what one of the presenters, Karen, said. It is not just elimination, but the lives we save along the way. So those of us who have been screened and have come out and able to come out and share our stories creates a big impact, just like what I've shared happened to me this past week. Thank you so much for listening.
Thank you so much, Sally, for your courage and for sharing your experience with us. So, ladies and gentlemen, thank you for staying with us, and thank you for, first of all, thank you for joining us. I'm sure you'll agree with me, we've had a fantastic webinar with excellent presentations, which, as you've seen on the in the chat, will be available to all of you. So it now leaves me to remind all of you that we look forward to seeing you in Munich in July of 2024, where there'll be further discourse and discussions around cervical cancer, HPV-related cancer. And we just heard that a satellite symposium on this very topic has been selected for AIDS 2024. So there will be more, and we look forward to welcome you in Munich in 2024. Once again, thank you to all our partners for making this webinar possible.